Thank you very much for your maiden speech in your career, I guess. And I think we go back to Germany now. Monica Biscaldi from Freiburg University gives a presentation on diagnostic criteria profiles, early indicators and symptoms in childhood autism and Asperger's syndrome.
Thank you very much, Chair, ladies and gentlemen. I'm going to present some data, preliminary results from a follow-up study of 78 in and out patients who had been first diagnosed in the years between 2000-2005 in our department, at our Department of Child and Adolescent Psychiatry, as having an autistic disorder. This first diagnosis was based on clinical assessment, and in the follow-up visit, a set of diagnostic instruments was applied to confirm the previous diagnosis and to assert that the patients really met the criteria for autism. We applied screening tools, which were just presented here by Ranulf Rau, the Marburger rating scale for Asperger's syndrome and the questionnaire of social communication, and then we developed in our department an inventory, an investigative-based inventory to prove the DSM-4 and ICD criteria, 10 criteria of autism. I will just say some words about this. And of course we applied now the in German now available instruments as gold standard instruments for the assessment of autistic disorders, ADOS and ADR, and finally a new cognitive assessment of intelligence. So, as about our Freiburg autism inventory, it was an instrument which was filled in by professionals on the basis first of clinical documents, and then it was completed as investigative-based semi-structured interview of the parents or the caregivers of the children if they were available. And the purpose of this instrument was to check up diagnostic criteria according to DSM-4 and ICD-10 of autism or Asperger's syndrome, as well as also to have information about age of parents' first concerns, early indicators of developmental abnormalities, attendance symptoms, chronology of the diagnostic procedure, diagnostic consultation, and therapy. And by the way, a multiple choice list of early and attendance symptoms was compiled by the professional on the basis of literature available on this issue, and this will be shown in the results. The purposes of our study were, first of all, to confirm diagnosis of autism by applying international gold standard diagnostic tools, and further to control for reliability of diagnosis within the autism spectrum disorders. And we considered the main categories of ACD, according to ACD-10, of childhood autism, Asperger's syndrome, and atypical autism. Then another purpose was to compare core as well as attendance symptoms, especially in autism versus Asperger's syndrome, and to explore early indicators of autistic spectrum disorders according to the retrospective parents' reports. Finally, we wanted to analyze the pattern of a diagnostic course the patients and their family experienced before they were referred to our clinic. is about the patient samples. As far we have the data of autistic children and Asperger children, and in the case of autism, out of 74 families with children who had been labeled as having autism at the first diagnostic course in our department, 55 could be successfully contacted and were asked to participate to the study. 10 families refused to participate, and in 5 patients, these are the first results, after follow-up visit, the criteria of autism, of childhood autism, could no longer be asserted, so they met now the criteria of atypical autism. For Asperger syndrome, 45 families could be successfully contacted, and in this case only 4 families rejected participation to the study. In 3 patients, information obtained at the time of follow-up visit turned out to be not reliable enough, and so the specific diagnosis of Asperger syndrome could not be confirmed. But they still belonged to the autism spectrum disorders. Only 1 girl turned out to have no autism spectrum disorder at all. So we could confirm the first diagnosis, the previous diagnosis in most of the patients, and finally 40 patients with autism and 38 patients with Asperger syndrome could be included in the analysis of the data. Now, about the patient sample gender distribution, we had 10% females in the group of patients group of Asperger children and adolescents, and more or less the same proportion of females in the group of high-functioning autism, and a little bit more, about 25% of females in the group of low-functioning autism. In these data fit very well with the data of the literature. Now, about the age distribution, we found also at a follow-up visit, and we will just in a minute see what the mean of this result, that the patients in both high-functioning disorder types were much older, with a mean age between 14 and 16, and the low-functioning autism had a mean age of 9 years. So it's about intelligence level. We had a mean IQ value of 100 in the group of Asperger patients, and slightly lower mean IQ value in the group of with a high-functioning autism. As for the group of low-functioning autism, we could obtain the IQ values with a current, for example, Wechsler scale for intelligence tests only in 8 patients. The other patients had intelligence value well below 50. So, and now I come to the results in the sense of presence and fulfill of criteria of impairment of social interaction in the 3 groups according to DSM-4 criteria. And you see that in all patient groups, the whole population in each sample of patients showed nonverbal impairment in nonverbal behavior, in the peer relationships, in emotional reciprocity. There were no differences between the groups, but there were some differences in the criterion of shared enjoyment, with patients with better intelligence level having less impairment than the patients with a low functioning autism. And now, as for the domain of the restricted repetitive behavior, we found that abnormal interests were represented in the same way in all patients group samples, but non-functional routines or rituals seemed to be a little more specific for Asperger patients, and on the other hand, motor mannerisms, stereotyped behavior was more specific for low-functioning autism, as well as also preoccupation with part of objects, and these group differences were significant. And now, as for the impairment of communication, you know that both in DSM-4 and in ICD-10, impairments of communication are not necessary to have a diagnosis of Asperger syndrome. But in our subject sample, we found that, of course, with the exception of delay or lack of spoken language per definition, all other category of communication, repetitive use of language, conversation, delay or lack of pretend play, were impaired in the same way in all three patient groups. So also Asperger patients were much impaired in these items. And these results were confirmed by the EDOS results. The EDOS was performed at the time of a follow-up visit in the slightly more older patient sample in comparison to the former diagnostic procedure, and you see that also for teenager high-functioning autism disorders, most patients could reach the cutoff for autism, and only some of the patients only reach the cutoff for autism spectrum disorder. As for social interaction, we had some differences between patients with high-functioning spectrum disorders and low-functioning patients with more social impairment of social interaction in the last group. So, and now we wanted to know which were the concerns, the first concerns of parents with an abnormal developmental delay or a functioning prior to age 3. And this issue is also supposed to be present in patients with autism, but not necessarily or not at all in patients with Asperger syndrome. And what we found was that once again, with the exception of language, as used in social communication, which was not impaired in Asperger patients, the other two categories of symbolic or imaginative play and social interaction were found to be impaired also in about 60% of the patients with Asperger syndrome, also at age prior to 3 years. And nevertheless, in spite of these first preoccupation and concerns of the parents, we found that when we considered the course of diagnostic consultation, mean age of first consulting of expert, of a specialist, was very high in both groups of high-functioning patients about 10 years, and there was a clearly delay toward mean age of first final diagnosis, where the patients were about 12 years of age. And there was some delay, I think, also in the low-functioning group, but it was not so dramatical. So now I will show you a little bit about the early symptoms in Asperger versus autism disorders, and in 3 minutes, which is a very short time. And you see that preoccupation with lack of social interest, no contact to peers, abnormal play, or distress reactions were very common in both patients with autism and Asperger syndrome, whereas other developmental delays, for example, and other symptoms such as avoid boy touching, eating disorder, repetitive pain, stereotype motor mannerism were more typical for autistic younger children. And finally, a hit list of attendant symptoms. On the left side, symptoms which occurred in autistic patients. On the right side, in Asperger syndrome. And first, you see that some categories were more specific for one group of patients. For example, once again, stereotyped behavior, hand and finger flapping, eating abnormalities, sensory-oriented behaviors in autism, and on the other side, abnormalities in communication, such as prosody and pragmatic, sleep abnormalities, hypersensitivity to temperature, motor problems in the group of Asperger patients, and some other symptoms, such as, for example, impairment in the use of non-verbal behavior, were only slightly more specific for autism, but also present in Asperger syndrome. Irritability, aggression, and distress reactions were much more present in Asperger syndrome, but also in autism, and also intense responses to sensory inputs seem to have some specificity to this group of patients. We have the same amount of attention deficits and hyperactivity in both groups. Now, I sum up the results in 1 minute, and I could state that children with Asperger syndrome exhibited the same social interaction problems than those with childhood autism, except of better development of shared enjoyment. Secondly, they showed a normal communication with respect to speech production as used for social exchange, but had a lot of other quality communication problems, such as prosody, pragmatic of language, conversation, also in the field of pretend play. Third issue, the communication problems in the Asperger syndrome were persistent and invariably present also in Asperger teenagers and also some adults subjects. Abnormal responses to sensory stimuli that could be attempted were most often reported by parents of children with Asperger syndrome. Maybe this is some specific, but not be certain, looked for. Further, attention deficits and hyperactivity were common in both samples. And once again, children with Asperger syndrome and high-functioning autism differed only in the first years of development. We found more communication problems, more stereotyped behavior in high-functioning autism. And similar to autism, a lot of parents of Asperger children became aware of problems in their development, in the development of their children prior to 3 years of age. But nevertheless, yet in all types of autism spectrum disorders with normal intellectual level, delays of up to 5 years could be found between earliest parents' concern and first diagnostic consultation, and final diagnosis was further delayed of about 3 years, very late. So my conclusions are, first of all, the study confirms other critical statements in the literature about difficulties with the diagnostic criteria of Asperger's syndrome. You find other operational criteria in the cited works. Research effort is necessary to better define phenotype profiles and we think more dimensional profiles of autistic disorders, and last, improvement of early recognition of autistic disorders, especially in high-functioning children, as well as diagnosis really comorbidity or only attendance syndrome. We don't know as yet. For example, ADHD are central issues since there is now some evidence that they could be crucial factors also for the outcome of the individuals with autistic disorder. Thank you for your attention.